Hi, thank you for joining us again. I'm Rebecca Starkey, as you might remember from last time, and I'm here again with Kimberly Skellington, a genetic counselor who has offered to be here and help with the presentation on midwives and genetic counseling. This is the second session, and we really appreciate you taking the time to complete the first survey and watch our first session. And hopefully you get a lot out of this second session and encourage you to complete the second survey as well. We're really excited to share this information with you and really want it to be useful and helpful to you. In this session, we will cover the communication aspect of prenatal genetic counseling. I'm sure you have all heard of midwifery referenced to as an art and a science. Kim gave us a really thorough overview of the science part of prenatal genetic counseling in the first session. This discussion on communication deals a little bit more with the art aspect, but there's definitely a scientific basis to it. Here are our objectives for this session. By the end of the session, any midwife who has participated should be able to identify barriers to risk communication in prenatal genetic screening, recognize the importance of shared decision-making and informed consent in prenatal genetic screening, implement risk communication strategies that facilitate informed consent and shared decision-making in prenatal genetic screening. Who do we screen? As a reminder from our first session, all organizations that are concerned with prenatal genetic counseling, which include the American College of Obstetricians and Gynecologists, the National Society of Genetic Counselors, and the American College of Genetics and Genomics, recommend counseling all pregnant people on their options regarding prenatal genetic testing and screening. So this includes non-invasive prenatal screening, first trimester screening, second trimester screening, combined screenings, and diagnostic testing options. And this applies to all pregnant people, regardless of their age or any other risk factors. How do providers and patients decide? In our first session, we considered how testing options and attributes influenced how providers might decide which test to offer and how these attributes might influence patients' decisions regarding which tests to use. How we as providers communicate that information and how patients understand it are equally important. So we will consider first risk communication, then risk presentation, and then how those components influence the informed consent and shared decision-making process. So first, risk communication. Risk communication is complex. The approach to counseling about risk has changed dramatically since genetic tests were introduced in the mid-1970s. The concept of risk communication as being important to healthcare also emerged in the mid-1970s, and the ideas surrounding risk communication have evolved since then. Additionally, the screening and testing options for genetic conditions have evolved. They've experienced a somewhat parallel evolution. And during the same time frame, people have had an ever-increasing access to information. This influences what we as midwives tell patients and how they understand it. So this slide compares risk communication, how it was historically, and what it's like currently. Initially, before risk communication was even recognized as an important concept of the healthcare process, it was an expert healthcare provider just disseminating information, making their recommendations, and a passive client receiving that, then typically going along with it. This fell out of favor beginning in the mid-1990s when we recognized that the things that we do to a patient should include the patient's perspectives. We recognize that this isn't a one-way, you do is what I say, and that it requires a conversation. Keeping that evolution in mind, there are factors that influence communication from the midwife's perspective. Midwives and providers must clearly communicate scientifically advanced information. The information that Kim shared with us in the first session, such as the prevalence of the condition, the accuracy of the test, the risks associated with testing or not testing, any alternatives, and management options if the test indicates a possible problem. Furthermore, this isn't straightforward. The risk for the most commonly screened for disorders varies based on a variety of factors. Additionally, the communication that we engage in regarding prenatal genetic screening and testing is time sensitive. As we all know, prenatal appointments are time limited. Additionally, any prenatal intervention that happens, or if termination is a consideration, might be dependent on a specific gestational age. Furthermore, risk processing is nuanced. This is a table that we included in the first session. It is here to demonstrate that even for the more commonly screened for disorders, the communication regarding screening options is complex. As midwives, we have to tailor our message based on the disorder, the screening, and the person's individual risk factors. For instance, for cell-free DNA, the positive predictive value for a 40-year-old's trisomy 21 screening is as high as 99%. But if we look at the positive predictive value for a 20-year-old's trisomy 21 screening, it can be as low as 38%. And then looking at that same 20-year-old's trisomy 13 screening, the positive predictive value can be as low as 5%. This can be very confusing and requires us to be very deliberate with our counseling. Just as there are factors that influence midwives' risk communication regarding prenatal genetic counseling, there are factors that influence our patient's perspective as well. These include personal attributes, things such as cognitive skills, such as health literacy, their ability to interact with health information, from accessing the information to interpreting it to applying it, and things like numeracy, which is a specific component of health literacy. Numeracy is a person's ability to access, interpret, and communicate mathematical information. Additionally, people's emotions affect and are affected by risk communication surrounding prenatal genetic screening. For instance, people's beliefs regarding how or why a disorder occurred, what its prognosis is, and what that means for their future child and their own personal lives, and their beliefs regarding management options affect their emotions. Their perceptions of vulnerability may influence their emotions. Any familial or personal experience with a specific condition or any other disorders that they may have experienced may influence how they react emotionally. Furthermore, any fear or anxiety or uncertainty may influence how they receive information and how they make decisions regarding prenatal genetic screening and testing. In a qualitative study of 25 pregnant people, researchers found that patients who readily accepted screening or deliberated tended to find the information that they were going to get from prenatal genetic screening to be anxiety relieving or at least emotionally neutral. But the patients that declined screening tended to find the information that they would get from screening to be anxiety inducing. How we present risks can influence patients' emotions. We've all heard of the patients that felt that the way that the risk was presented was more of a problem than the actual risk of the disorder itself. Finally, how patients perceive risk is influenced and influences their emotions. For instance, the prospect theory tells us that people tend to overestimate the likelihood of being affected by something when it is serious or when its occurrences are exceedingly rare. Just as risk communication plays a role in prenatal genetic counseling, risk presentation also plays an important role. Risks can be presented in a variety of ways. We can present risk verbally. We can tell a patient that they have a 1 in X chance of something happening, or a specific percentage of it occurring. We might present risk as a level of likelihood. You're highly likely for this to happen, or it's unlikely for this to happen. We can give them that same information in written form. And a very common way to present risk is with a visual representation. So graphs, scatter plots, pie charts, pictograms are all common visual representations that we use to communicate and present risk to patients. Many studies have been done on these various methods without any superior method being identified. What the studies have demonstrated is that age, education level, and client preference are all considerations, but are all variable when presenting risk. As midwives, we are aware of the importance of informed consent and shared decision-making. ACOG has outlined the essential elements of the informed consent process. So these include the diagnosis. So when we're talking about prenatal genetic screening and testing, we would be talking about the specific disorders that the tests or screenings can identify. The nature and purpose of the proposed intervention. So if we're thinking about cell-free DNA, we would discuss the blood test and all of the information regarding cell-free DNA that Kim shared with us. possible alternatives. So, the possibility of doing a diagnostic test instead, deferring to the anatomy screening if there is a problem indicated but not diagnosed, or not screening at all, are all possible alternatives. And for each specific situation, these alternatives are going to be specific as well. And the burdens, risks, and expected benefits of all of the options. And in order to apply this, as midwives, we need to assess the patient's ability to understand the information that we're providing and the implications of the testing options and alternatives, and their ability to make an independent and voluntary decision regarding these things. We also have to present the relevant information accurately and sensitively, consistent with the patient's preference for receiving medical information. And documentation, charting, everyone's favorite. We've got to document the informed consent conversation and the patient's decision. There are some specific challenges to informed consent in prenatal care. These can be evident when a patient has a perception that a specific course of action is preferred. For instance, if the patient is making a decision based on the perception that screening or testing is the socially acceptable course of action, or that their decision is tempered by the idea that everyone around them might feel that termination is the right decision, or conversely, the wrong decision. And sometimes we see this with patients where they choose not to test because of the risk of the testing or screening being wrong. How we approach procedures based on their risk is a challenge to informed consent in prenatal genetic screening. The counseling that we do tends to be based on the risk of the procedure, especially with prenatal genetic counseling. So diagnostic testing that's invasive, so amniocentesis or chorionic villus sampling, we tend to present the information very stringently. It's very clear to all that are involved what we're looking for, what the procedure entails, what the risks of the procedure are, what the alternatives are, and the patient makes a very clear decision to either proceed or not with the procedure. With cell-free DNA and other screenings, the risk is less. We've all heard and maybe said that it's just a blood test, or that our patients perceive it as the gender test. This can serve to make screening routine and can erode the informed consent process. Being aware of the elements of the informed consent process and applying them to all of the prenatal genetic testing and screening we offer is necessary for people to be able to make an informed, autonomous decision, which is at the center of shared decision making. So I'm going to talk a little bit about some decision making styles we all may have seen before. We've all seen our intuitive patients, the patient that is going to go with their gut or just knows that everything's fine with the pregnancy. We've also experienced the agonizing patient, the patient that just doesn't know, I don't know what to do. What would you do? needs help making the decision. The patient that is delaying, I don't know. I'll let you know at the next appointment. Or alternatively, the impulsive patient. Yeah, just do it. Go ahead. Unfortunately, we've all experienced the fatalistic patients. I just know something is wrong with this pregnancy. And, sometimes their intuition is right. And regardless of right or not, it's always a hard thing to work through. The compliant patient. Yeah, I'll do whatever you say, whatever you think is best. The paralytic patient. I just can't decide. I don't know what to do. And the planful patient. If I get this information, then I'll be able to do this. Or if the information is that, I can go with this plan. You almost will never have a patient display just one of these decision makings. They tend to kind of be together in concert, but it's helpful to think about them when you're considering patients' decision-making styles and how to tailor your message to them. So we are going to revisit the role play from the first session, our 34-year-old G6P5, who is about 8 weeks along. Very, very normal obstetric history, no history of any miscarriages. She does have the one child that's got an incredibly rare genetic disorder. He was diagnosed when he was 26 months of age by a whole exome sequence. There was no indication of this during her 5th pregnancy. Child is her 5th child. And child displays some really significant global developmental delays in like the 1st percentile for gross motor stuff, 1st percentile for speech with very limited to no speech, both expressive and receptive, some significant hypotonia, significant feeding issues as a baby, and some seizures as well. So during her 6th pregnancy, the situation required risk communication, and we'll see some of the different decision-making styles in this scenario. The patient was very well informed about the disorder. She was aware that the mutation was de novo and that recurrence was incredibly unlikely. She'd waited to get pregnant until she had gotten the diagnosis for the 5th child. So she had delayed her 6th pregnancy, intending probably not to get pregnant, but when she realized that this was a de novo mutation, she and her husband decided that it would be, probably safe to expand the family. But once she did get pregnant, she was really anxious. She had some of what we see with the prospect theory. While it was exceedingly unlikely that another pregnancy would be affected, and she even knew this, she was overestimating the possibility that it could happen to her. So first she agonized with the decision to get pregnant, and then she agonized with what to do. And one of her fears was surrounding the birth. She had had 3 previous home births, including with the affected child. She'd had a really, really nice water birth, actually. And it was a quick and calm birth. Nothing went wrong. The baby needed a little bit of stimulation, but
actually was perfectly fine. However, he was hospitalized when he was 8 days old for some cyanosis. And that was something that she was definitely apprehensive about. So she felt that if she had some additional information, it might reassure her about having another home birth with this sixth pregnancy, or she might plan to do things differently if she found out that there was something significantly wrong with the pregnancy, even if it wasn't the disorder that her other child was affected by, that she might do things differently. Before she even got pregnant, she knew that she wanted non-invasive prenatal testing, and she wanted to do MSAFP. But she kind of struggled with this. She knew that the disorder was really unlikely to repeat, but she still was like, lightning strikes once until it strikes you twice. So she eventually decided that seeing MFM and seeing a genetic counselor were going to be the best for her situation. So she did see the genetic counselor and decided that an amnio was the best course of action. She missed the chorionic villus sampling timeframe, and so she proceeded with amniocentesis, did a karyotype, did a single gene diagnosis for the gene that her other child had the de novo mutation on, and she decided to proceed that way because in the end she felt that knowing ahead of time if she was going to have a baby that needed support, even if it wasn't the same support that her fifth child needed, was going to be helpful to her. She wanted an opportunity to get anything that she could in order ahead of time. And she wanted to organize those resources and plan for her family's future. So that brings us to preparation as a reason for testing. As we saw with that scenario, she did have kind of that planful mentality. She had some of the agonizing. She experienced some of that prospect theory. She had a little bit of it all going on. But what we're seeing is patients increasingly choosing to test or screen with preparation in mind rather than termination as a goal. And that was the case in that particular scenario. She did not plan to terminate if there was a problem. She just wanted to make a plan. But what we see in the literature when we study preparation is that preparation means different things to different people. So for some people, it might mean clinical activities. They might want to know if their baby is affected by a disorder that could benefit from increased prenatal surveillance, or if there are prenatal interventions that might be helpful. Some patients want to plan for delivery or immediate neonatal care. In fact, one of this lady's plans was that if she was going to have a baby that had hypotonia and was at risk for feeding disorders, that she was going to get breast milk ahead of time. For some people, preparation means more social and informational support. They want to know what life is going to look like for them with a child affected by a disorder. Some of them want to interact with other affected families, or, really dive deep into what the prognosis is, or what their quality of life is going to look like. How is it going to affect what they had expected their lives to look like? And for other people, preparation is most important to their psychological coping or adjustment. They might need time to grieve what the expected child's normal life was going to be like prior to the child being born. It might mean, updating what they envision for their future reproductive needs. So, researchers also find when studying preparation that patients experience some specific limitations, particularly that preparation isn't the same for each condition. Each condition that we screen for is unique and requires unique considerations. Patients also said that when they were seeking preparation and received a diagnosis, that number one, they tended to feel dissatisfaction with the delivery of the diagnosis, that the information that they received tended to be negative and outdated, and they weren't guided to appropriate supports. So this tended to result in more worry and anxiety rather than the preparation that they were looking for. So with these things in mind, we have to put it all into practice. How do we find a happy medium? First and foremost, we maintain shared decision making with the patient as the decision maker, regardless of the clinical scenario. Take the time to discuss the different aspects of the screening and testing with each patient. Recognize that preparation has a variety of definitions dependent on multiple factors of the individual and nuanced situations that you might find yourself in, and develop a repository and network of resources for patients. Some things to remember when you are communicating about prenatal genetic screening and testing and providing prenatal genetic counseling. Determine your pregnant patient's preferred way of having information presented. Do they need written material? Would it help if we looked at a graph? Dive into those things, find out what's helpful. What is the most important thing to that person about prenatal genetic screening? What is the most beneficial information that they will gain from prenatal genetic screening? And remembering that when we present risk, the most effective and preferred presentation varies dependent on a variety of characteristics, including cognitive skill strengths and weaknesses. When we present risk, consider using pictures and health education materials. And if you have written health materials, organizing it with headings. For some people, depending on their literacy level, delivering health information orally is going to be the only option. Some patients like narrative vignettes that illustrate a point. They find those helpful. Limiting the amount of information provided at one time. And again, that's hard. Like we said, prenatal appointment times are limited. So sometimes it requires scheduling another appointment or, collaborating with our consulting maternal fetal medicine physicians or our prenatal genetic counselors, having them supplement the information and not providing it all at once. Remembering that providing explanations for when you provide explanations for risks and numbers, that just saying the number has an effect on comprehension. So sometimes it's really helpful to present both sides of the risk. If you have a 25% risk of having the condition, there's a 75% risk of not having it. And using the decision aid. So there are a couple of decision aids that are specific to prenatal genetic screening and testing that are available. They're all very similar and all useful. The available decision aids are specific to the health systems that they were developed in. So they do need some editing to use in your clinic if you want it to be, your own thing. Additionally, there are some studies on some more technologically advanced, because the existing ones tend to be like pen and paper type decision aids. But they're the more technologically advanced. There's a computer game one, there's an app. They're all in trials now and being studied. All of these decision aids can be evaluated with an instrument that is meant to help evaluate decision aids. It's called the International Patient Decision Aid Standard. The available decision aids, the pen and paper ones, are all score highly on the instrument. And the ongoing testing on the more technologically advanced decision aids, the studies suggest that they help pregnant people make decisions regarding prenatal genetic screening. And the literature regarding decision aids in general indicate that the decision aids are helpful when making a difficult decision. So this slide is a portion of one of the available decision aids. It starts with an overview, up higher, there's several sheets long. And the first sheet starts with an overview of why we offer screening. It includes risk factors and overviews of the commonly screened for disorders and the available test. Then there are a few tables, one comparing the risks and benefits of each test. So there's several tables, one for each test, and then a table of the risks and benefits of not testing. And then there's this information on the next page, which lets the patient write down benefits of testing, benefits of not testing, potential harms and of testing, and potential harms of not testing, and helps distill it down to those most important things. And then the decision aid asks them to make a decision with an option for I don't know, and then helps them evaluate if they are comfortable with the decision they've made. So these questions are yes or no questions. Do you feel sure about the best choice for you? Do you know the benefits and harms of doing or not doing the test? Are you clear about which benefits and harms matter the most to you? And do you have enough support and advice to make a choice? And with this SURE test, the patient should answer yes to all of these to indicate that they are making a decision they are comfortable with. So here are some resources. There's a resource, and it's specific to Canada, but it contains guidelines that are helpful. So I've included it here for pregnancies that are diagnosed with Down syndrome. Also, the American College of Medical Genetics publishes ACT sheets, and these include overviews of the test and its carrier testing and aneuploidy screening and a bunch of different tests and algorithms, and they're simple but helpful. And then a link to one of the decision aids. And like I said, if it's something that you want to use in practice, it'd probably be good to edit it so that it's specific to your practice and not the practice where it was developed.
So you do not have to read this whole page. We'll definitely set the stage as to what's going on. So these are kind of just some notes that we had, but this is really coming from a case that I had in clinic, which really had a lot of risk assessments and risk figures that the patient had to, figure out what to do with. So this is a patient who came to clinic. She already had one child. She had a daughter, and her daughter had autism and developmental delays. And the daughter had gone through being evaluated by a geneticist, and they did run that microarray test that we discussed, and a microdeletion was identified for her. The microdeletion, when you look into the literature, it's something that has been reported before, so it's not one of those variants of uncertain significance that I brought up as a risk of doing a microarray. So it is something that is linked with autism and developmental delays. And so the geneticist felt that this was the underlying cause for her daughter's features. Now, this microdeletion and microdeletions in general, as well as microduplications, they can be inherited by an apparently unaffected parent. We do see this a little bit more frequently when it's a microduplication, but nevertheless can happen. And so the geneticist did test both my patient and her husband to see if either of them could have also have this deletion to better understand reoccurrence. And so this was performed. My patient did have the deletion. And so, she was found to have this. However, she had no features of this condition, which can be consistent with some microdeletions. It's called reduced penetrance. So what that means is even though she has a deletion, it doesn't mean she will have those features. So we knew, and she knew as well, going into this current pregnancy, she was about 10 weeks, or a little bit farther from that, where she had a 50-50 chance to pass that deletion on. So for her, she felt that was a high chance. She felt that she would want to proceed with diagnostic testing for pregnancy because unfortunately cell-free DNA testing would not have evaluated her microdeletion. So with what we were doing, we did perform the amniocentesis, and the baby was found to have the deletion. So the conversation that needed to occur was, well, what would she like to do with this knowledge? She knew this baby had this deletion just like she herself had, but also that her daughter had, who ended up with clinical features. From literature, what was reported is that the penetrance was about 10%. So that means of people with this deletion, about 10% of the people will have the clinical presentation. However, most people would not. So that is what we had to kind of navigate through of how do you decide on that number, whether to continue this pregnancy or not. And so we were going to try and role play this as me being the genetic counselor and Rebecca being this patient.
Hi, Kim. How are you?
Hey there. Thank you for coming in. So I know that we, just talked over the phone about these results, and we've confirmed that for this baby, she's predicted to have this deletion as well. So how have you been doing since hearing of that news?
It's been a whirlwind. I know I have it, I guess, but I'm fine, but my other daughter has it and she's not fine. And I just don't know what to think. I don't know what to do. I know, like, my other daughter, she takes I love her. I love being able to do everything that I do with her, but I can't imagine having another child that has the same needs and how I can keep all of us alive if we. I have to do that again.
Mm-hmm. And that's definitely kind of where we're at, in that we know, this baby has the deletion, but we don't know if she's also going to have some of the same features as your daughter. Now, based on literature, the prediction is that when someone has this deletion, about 10% of people will actually have, autism and developmental delays. Do you find that 10% feels like a high chance, or do you feel like that's relatively low? The other way to view it is that 90% of people, such as yourself, do not have any clinical presentation.
Right. I go back and forth. 10% doesn't sound like that much, but then when I think about the fact that it's, you think about it in two different ways, like lightning only strikes once, but what if I'm the person that 10% means this next baby has it too? I'm struggling with it. It did help to hear that, yeah, here's the other side of it. 90% of people don't. And yeah, I am one of those people, but I'm really struggling with what to do.
And that's definitely reasonable. I mean, you've been that person where that 10% was applicable for because of your daughter's presentation. So yeah, you kind of might feel that number is higher because you've actually experienced, that 10%. In another way to kind of think about it too, if we had a room full of people and there were 10 people in there, this is to say they all have that deletion. Well, one of them is the one who's actually presenting with autism and developmental delays. And if we think about your family as well, this is something that you might share with some of your siblings or parents. I know they haven't had testing, but, really could be, in that realm of, 1 out of 10 is that expectation. So it kind of feels like, will this baby be that 1 out of 10? Or will this baby be, those 9 out of 10?
Right. That is helpful. I'm still torn. I just don't know what to think. And I know that all of it'll fall on me if this baby does need extraordinary care.
Right. So it's kind of, you face the reality that, if this baby has this condition, you're the one who's having to do the day-to-day life and add that on to the care that you provide for your daughter. So is it something that you feel like you would handle? And so we could walk through kind of these two scenarios. So let's say that, you do choose to terminate this pregnancy, knowing that 90% chance this baby would not have had autism and developmental delays, versus continuing the pregnancy, knowing there's a 10% chance that the baby will have autism and developmental delays. So kind of walking through each of those scenarios, which ones do you think personally would be worse? Taking that chance that, the baby won't have these features, or maybe better yet, taking the chance the baby could and continuing the pregnancy, or, knowing that maybe you're terminating a pregnancy where the baby wouldn't be affected. What kind of feels worse to you?
I do. While I'm very nervous about the prospect of having another baby, I'm hopeful, and I know I say that I can't do it, but obviously I would do it if that's what I needed to do. So I do think that I would go ahead and continue the pregnancy, just knowing that, we might need support down the road.
Yeah. And how do your family members feel about this as well?
I don't get a lot of help, so I don't know how I haven't really considered a lot about how they feel, because I their opinion on it is not based on what they're doing what responsibilities they're taking on. So I'm just, I do feel alone in it.
Which is challenging too, because there really is no clear right answer. It really is just up to you and kind of what you're comfortable with moving forward. So yeah, it is hard when you're the only one who's having to make that decision and kind of having to identify what's best for yourself and for your family at large. So yeah, it's not that anything you have to decide right now. But it is something, you know, if you do find that you'd like to either pursue a termination or continuation of pregnancy, you know, we can always touch base in a couple of days and kind of let you sit with this and kind of, you know, feel maybe each scenario out and what seems like the way you want to go. And we can always just touch base and circle back.
Yeah, I think I'd like that.
Okay, awesome. And see. And as you all see in this slide as well, you may have been reading this as we were role playing. You know, for the patient, you know, the father of the pregnancy was brought into the conversation, and he just felt like there was a good chance that the baby wouldn't show any of those symptoms. So he very much wanted to proceed. But, you know, like as Rebecca was saying, you know, she really was the sole caregiver. So she was the person to really, you know, have to be the one to, you know, care for the child no matter what. So yeah, so it was definitely a challenging situation. Really, again, no clear right or wrong answer. But this is just an example of, you know, you're using these numbers to really make these substantial decisions, and just, you know, how can a patient really internalize what these numbers mean for them. So that's kind of what this was role playing or attempting to do so.
Yeah, I think it was a great role play. Since we didn't have a father of the baby here with us, I did change it a little bit on the fly just to.
Yep.
We've all been in that clinical scenario when it is the mom doing it all.
Yeah.
So it was an easy one for me to kind of ad-lib.
Definitely.
And with that, here are our references. And again, thank you all so much. At the end of this presentation, there will be the link to take the last survey. We appreciate your patience in watching these. We hope they were helpful, and we really, really greatly appreciate you completing the surveys. Thank you.
Thank you so much. Take care, everybody.